So here what I discuss is the predicament of inhibitor in developing countries. And I think there are so many things to discuss about this topic that became quite a big issue in our countries. So here are my disclosures. So when we analyze the WFH annual global survey from 2008, that actually include all the data from 2004 to 2008, with more than 180 countries, we could see in comparison to the annual global survey in 2016, the last one that is available, that we had an increase in terms of the mean global factor consumption. So as you can see, we have an increase in terms of the factor 8 and factor 9 per capita. But it's actually quite interesting to notice that when we evaluated the prevalence of inhibitor back in 2008 in the total hemophilia A and total hemophilia B is actually higher in comparison to the prevalence of inhibitor in 2016 if we consider all the countries. And I'm talking here about the prevalence, so how many patients we have at that time, and not the incidence. So it's also a fact that there is an increase in the global consumption of the all clotting factor concentrates. And here in this graph, we have some results of the Marketing Research Bureau. And in gray is the recombinant clotting factor concentrates, and in green, the plasma-derived factor concentrates. As you can see, since the recombinant products became available at the market, there is a significant increase in terms of the clotting factors that is available. So back in 1994, we had the consumption in the world was around 2.1 billion international units. In comparison to 2015, that was 7.7 billion units. So now back into the comparison about the survey in 2008 and the survey in 2016. But now what I actually analyzed is to divide some of the data according to the countries that was dividing according to the gross national income. So as we can see here, the mean factor 80 per capita, if we consider the countries with high income, so developing countries, in terms of what we are seeing 2008 to 2016, there is an increase in the factor 8 that is available per capita, and it is also happened in the other countries, B and C, that it's the upper middle and the lower middle income countries or developing countries. But as I said to you, there is a difference in terms of the prevalence of inhibitor, and here we can notice that for the developed countries, the high-income countries, the prevalence actually is lower when we compare 2008 to 2016. On the other hand, in developing countries, B and C, the prevalence of inhibitor actually increased. So there are some possible explanations about this data. And let's think about why the prevalence of inhibitor in the total hemophilia A decreased in high-income countries. One possibility is because of the success of ITI, immunotolerance induction, that was using during all this year in these developing countries. And this can be actually noticed in this report in 2011 with the data from the Canadian Hemophilia Registry. As we can see, from 2003 to 2009, there is a decrease in the total inhibitor prevalence in all patients with hemophilia A, and this is particularly substantially when we are analyzing the severe hemophilia A patients. And one of the explanations for that is the availability of ITI. On the other hand, if we think about why is increasing the inhibitor prevalence in the developing countries, there are some possible factors that can contribute to that. And here is some of my own perspectives or some of the literature that can put us to think about the reasons why this is happening. One, as I showed to you, there is an increase of the product's availability, even in developing countries. With that, actually became possible also to adequately treat especially severe bleeding episodes, what means that they are also treating intensively. That is one of recognized risk for inhibitor development, and also is possible to do some procedures. Although the products are increasing in most of these countries, it's not enough to actually have prophylaxis available. So in most of the countries, the on-demand treatment is still more prevalent than prophylaxis. The other issue is we are also having more recombinant products in developing countries. And although it's a little bit controversial, if this will significantly had a significant impact in what I'm showing to you in terms of the increasing prevalence of inhibitors. And we also needed to think about that we are now treating distinctive populations, that is exposure to factor 8 and 9, with different ethnicity. And as we know, race is also considered one of the risk factors in terms of the inhibitor development. So it's possible that with that, in different populations, we are also seeing some increase in inhibitor development. Other aspects that is also possibly contributing to this is the improvement in the diagnosis and or the identification, the registry of the status of the patients with inhibitor in these developing countries. And in the opposite, that's what I just showed to you in terms of the developed countries. In these developing countries, usually ITI has a quite limited access. So again, take a little bit closer in terms of the prevalence of inhibitor in 2016. Here, the total inhibitor among the hemophilia A patients, we can see that the majority of these inhibitors were actually related to developing countries, high income, and also upper middle income countries. But what is interesting is in terms of the new hemophilia A inhibitor that was described in 2006, as you can see, in terms of the percentage of the new cases that was described in this survey, the majority actually belongs to lower middle income countries. So with that, and then I look closely to each of these countries and what is the possibility to that, I may say that this can be result of the improvement in the diagnosis and our identification registry of these inhibitors among these reported in these countries. But saying that, I also wanted to share with you some data from Brazil in terms of the inhibitor status. So the last survey that was published in Brazil is the data from 2015. And as we can see here, among close to 10,000 hemophilia A patients, it was reported 6% of positive for inhibitor. And closer to 2,000 hemophilia B patients, we had around 1% of positive inhibitors. But I must say that this positive of inhibitors doesn't mean that it's really the quantification that was done. So there is possibly some limitations in terms of the access to the laboratory diagnosis, and this was just recognized as a positive or a possible inhibitor patients. But one thing that I wanted to highlight here is that 21 to 22% of these patients in this survey actually had not informed the inhibitor status. And this can be either because of the lack of information or also because of the lack of access to the inhibitor test. So in 2016, when we analyze among each of the countries divided by the GNI, what we are seeing is that 90% of the patients under the age of 18 were on prophylaxis. But in the countries that is classified as upper middle income, this was around 57.5%, and the lower middle income countries, this is around 80%. So as I already showed to you, probably on-demand treatment is still predominant in lower middle income countries. And in terms of the percentage of the recombinant that is used in these countries, we could see here that in 2016 it was reported that 79% of the total factor VIII used in developing countries was actually recombinant products. And in upper middle income countries as B, it was just 11.5, and it was a very low what was reported among the lower middle income countries. So actually the percentage of recombinant factor VIII used in these middle income countries, in developing countries, is still quite low. But saying that, I also want to show to you what happened in Brazil. So in terms of the percentage of the recombinant factor VIII that is available there. So we just started to have access to recombinant factor VIII in 2013. And as we can see in the beginning, we have around 30% of recombinant factor VIII that is here in green. And in yellow, 70% of different plasma-derived factor VIII products. But early 2016, this is the opposite. So we have now, and this is what we maintain, the percentage is around 70% of recombinant factor VIII and 30% of plasma-derived. And this happened because of the deal that the Ministry of Health in Brazil had with one of the pharmaceutical companies in terms of the PPD to translate the technology. So I hope I already could show to you, and you are convinced that yes, inhibitor is increasing among developing countries. So now we need to deal with these patients, and we need to treat them in the best adequate way. So there are several challenges when we talk about the management of inhibitor in developing countries. And I will start saying that the data that is available in terms of the hemophilia care, and especially related to inhibitor in developing countries, is very, very limited. One thing that I can anticipate to you is the limited access of the diagnostic facilities. As Professor Ostermark just showed, how complex and the variability that we have in terms of to evaluate laboratory the inhibitor in the laboratory, and it's quite difficult to find the high quality and precise data in several countries, and even to be consistent in terms of the results. But we also have a limited availability of ITI and bypassing therapy. So in terms how we can manage the bleeding episodes, one thing that is recommended is what we are seeing in developing country is when it's available. Usually bypassing agent is just used on demand, and it's very rare that we can have access to prophylaxis using bypass agents. But in fact, when we talk about all the countries that actually has a very limited access, the resource is very constrained, not even bypass agent is available, and this is a reality that we needed to face. So many times what happens in these countries is that some of the healthcare professionals take the consideration to just use replacement therapy when is a severe bleeding. The way that if you avoid to use the replacement therapy in mild bleeding episodes, then you can prevent some anamnestic response, and this can help later on to use in a more severe bleeding episodes, high dose of factor VIII. And this is a reality. It's also very common to use other alternatives as better pain control, antifibrinolytic agents, and use some approaches as price for the joint bleed. Probably here not the P or just the RICE, rest, ice, compression, and elevation. And there are also other procedures that can be done, for example, using the radiosynovectomy to control the synovites is actually quite effective for these patients. But one thing that I would like to invite you to keep in mind that when it's possible, consider to do ITI even if you have some restriction in terms of the product that's available in our country. And saying that, we needed to take in consideration that although the high-dose ITI treatment is very expensive, as what we are seeing in bone protocol or MAMO protocol that add immunosuppression, we also have some experience in the literature related to the use of low-dose ITI, as the Dutch protocol using 25 units per kilo every other day. And although here what I presented to you, the success rate has some variability, and we cannot really compare between them because even the criteria of success was different among this study, I can guarantee for you that for some patients, the Dutch protocol, the ITI with low dose can actually help. And based on this, I also wanted to share with you our experience in Brazil related to our immunotolerance induction program. So actually, ITI became available in Brazil in 2011. And the first protocol, we enrolled Hemophilia A patients with high-responding inhibitor that were younger than 18 years of age. And the reason was because of the 18 years is just related to how much products we have available for this particular program. There is no other scientific reason for that. All the cases actually experienced the first attempt ITI protocol. And the protocol that we start, it was VWF containing plasma-derived factor VIII concentrate at a dose of 50 units per kilo 3 times per week. So in 2013, we evaluate the program. We have a little bit more products available. Some of the patients had success. So actually, we consider to enroll all patients, Hemophilia A patients with high-responding inhibitor from all ages, including adults. And the protocol was quite similar, but at this time, we actually continue to use the product that the patient developed the inhibitor. So because now we were using recombinant factor VIII, so some of, especially the pediatric patients, start with the recombinant factor VIII. The initial dose was the same, 50 units per kilo, 3 times per week, but we take in consideration some milestones. If the patient had poor evaluation, then we can increase the dose up to 100 units per kilo daily. And here are some preliminary results. So between 2011 to 2015, we have 240 patients that were enrolled in the ITI program in Brazil. And this represents around 48% of the inhibitor patients at that time. And as we can see, in August 2015, we already achieved 48% of complete success, and also 32% of this patient also achieve partial success. In the partial success here, we consider that the inhibitor titer was below 5 Bethesda units, and more important, these patients were no longer using bypassing agents. So in total, we could say that 80% of our hemophilia A patients achieved at least complete or partial ITI success, and they were not using bypass agents. Unfortunately, I don't have the percentage of the patient that had a relapse of inhibitor after the protocol. We know that among the partial success, this is quite common. But I must say, even from my experience in my own center, that the majority of this patient continues to be on prophylaxis with regular factor VIII concentrate, and that is now personalized according to their need. So it's something that we needed to consider. I will say that we also had some challenges regarding this program, and the challenge was the difficulty for monitoring the ITI protocol. Some labs, some centers had actually the lack of regular inhibitor assessment, and this was difficult to evaluate how the patients were evaluating during the ITI. And very important, the evaluation of PK parameters for the ITI success was constantly postponed. And this actually affects our evaluation in terms of the time to achieve tolerance. That was not adequate. So that's one reason why I cannot share to you and compare to the literature, because many times what happened is the patient already had inhibitor negative, but the PK parameters was postponed for several months. And also we have some difficulties related to the patient's adherence. And just now I want briefly to share with you also one of the study related to cost effectiveness of low-dose ITI in adult hemophilia A patient that we experienced in Brazil. This was conducted in 7 Hemophilia Treatment Center, and this was part of Dr. Presotti thesis. And in this study, we retrospectively analyzed the severe hemophilia A with high-responding inhibitors older than 18 years that who underwent for the first time to the ITI protocol. And just before the protocol, they are using bypass agents. So the dose here was quite low compared to what I showed to you. Some patients that actually used the Dutch protocol, 25 to 50 units per kilo, 3 times per week. And the majority of patients were treated with plasma-derived and few patients with recombinant. We have 32 patients, and 7 of them, 22%, actually increased the dose up to 100 units per kilo daily. So this is a quite busy table, but I just wanted to show to you that 32 patients were enrolled, and 5 patients actually stopped the ITI protocol because of lack of adherence. And we have 18 patients, closer to 67% of complete success. And consider the same parameters for partial success, this was around 26%. In terms of the complete success, it took for the patient around 5.5 months to the inhibitor became negative, and that's when we decreased the dose for a more prophylactic dose for these patients. And 80% of the patients at that time were no longer using bypass agents. And keep in mind, we are just talking about adult patients. That's considered a poor prognostic patients. In terms of the bleeding episodes before, during, and after ITI, as we can see, when we analyze the 12 months before ITI, all the patients have quite frequent bleeding episodes that considerably decreased during the ITI and was close to negative due to the efficacy of the prophylaxis that was introduced using factor VIII after the success of ITI. When we consider the both group, the 18 with complete ITI and the 27 that had the partial and complete ITI response. But here I think is quite important in terms of the costs that this represents when we are considered just the cost of the factor concentrates. So actually, there is no difference between the 12 months before in terms of the cost of these products and during the period of the ITI. And for the patients that had a complete response and a partial and complete response. On the other hand, when the follow-up years, we can see that the cost of this patient decreases substantially. And this we are continue to see among these patients that we continue to follow during these days. So this is quite important. And one reason why I wanted to highlight that is because we start first to do prophylaxis with bypass agent in my country. Before ITI was available. We didn't have enough factor VIII to do ITI, but in that time we started to have more bypass agents, and this needs to be really think that it's cost effective to think about ITI even with low dose concentrates. So the conclusion of these particular studies indicated that ITI is worthwhile even in patients considered poor prognostic. Here I just show the adult patients. And it was very effective in terms to control and prevent bleeding episodes. And it also had a positive economic impact. Close to 80% of the adult patients here stopped to use a bypass agent after 2 months of they started the ITI with this low dose. And despite being a high-cost treatment, ITI can be very cost-effective, even in long-time inhibitor adult patients. So in summary of my presentation, what I would like to say is the occurrence of inhibitor among hemophilia patients from developing countries is actually increasing, and we need to think about that. There are considerable challenges in the management of inhibitor in these countries with limited access of the diagnosis, and also the limited availability of ITI and bypass therapy. ITI can be cost-effective, and we should consider every time that we can. And we now have new treatments, new alternatives for inhibitor patients. But it's possible that at least during the next years, the availability of these new treatments for developing countries will probably be very limited. So thank you for your attention, and I'm happy to take your questions.